Good afternoon. It's great to be here. Following two whirlwinds, differently, but a tremendous amount of information. Um, I'm going to have much less information, and really just want to leave you with two things, start and end. First, as Helen said, and Sherry, we need a much bigger investment in the development of quality measures if we're going to do anything that is useful with them. And second, and this is sort of in contradiction to the first, we should be really sanguine, reticent, careful about the use of quality measures in payment programs. And that is in part, you might say, well, why should we invest more if we should be careful? But I hope in 8 minutes from now or 10 minutes from now that those two things will be a little bit clearer. So I'm going to step back a bit from where Helen and Sherry were and talk for a few minutes about when does it make sense to try to use strong financial incentives to get what we want from medical care, and when not, also known as the apple pickers and federal judges problem. And I should say that some of what I'll be talking about today comes from work that was done in a special issue of Health Services Research published last November that AHRQ sponsored. I used to be the director of AHRQ. We sponsored an issue of HSR, and I'll be drawing from material in that today. Second, and I only have one slide on this, but I think as we are having these conversations about how and whether we should be using measures of quality in payment, that it's important to have a shared understanding, or at least some understanding of why it is and how it is that quality improves in healthcare. And third, I'll spend a few minutes on special considerations for high needs patients that we're all here today to talk about. So this first question, when are strong financial incentives appropriate, and what do we do when they might not be? This comes from a talk actually that I heard Bert Weisbrod, who's an economist at Northwestern, give about 20 years ago. Although as far as I know, Bert has never written this up. And Bert asks his audience to think about how we pay apple pickers, the ultimate pay for performance. We pay them for every apple that is picked. If they perform and pick an apple, they get paid, otherwise they don't. And he contrasts that with how we pay federal judges. Lifetime tenure, salary unconnected to any measure of what they do. So the ultimate divorce of pay for performance. And Bert says, well, why is that? Well, maybe it's the greater power, political power of federal judges, but Bert says, actually, no, there's a good reason for this, that we, in apple pickers, we can measure very well what we want them to do. The cost of measurement is low. We don't worry about gaming. We might worry a little bit about whether the apple is bruised, but we can inspect the apples and try to deal with that. Federal judges, exactly the opposite. What do we want judges to do? We want them to produce high quality justice efficiently. How do we measure that? Well, efficiently, we could try to measure the throughput of cases or how long it takes them to resolve a case. But if they can have any influence over the cases that they select, they could easily game that measure. And even if they can't, they could stint on the quality of justice and get cases through more quickly. Can we measure the quality of the justice, the quality of the decision making that they make? Very hard. And so we rely on federal judges on selection and professionalism to try to get good performance. And then, Bert says, well, where's medical care on this? Where should it be? Now, historically, of course, we've paid physicians like apple pickers. We paid them for everything that has been done. But increasingly, we realize that's not what we want. We're not getting the performance that we want by paying fee for service. And so we're moving appropriately and correctly, I think, away from fee for service towards larger bundles, either capitation, the sort of ultimate bundle, or things in between. But then the question is, we're doing that is, well, to what extent should we be adjusting payment for the quality that we measure? And I'm going to actually come back to this. Milgram and Roberts, in a 1992 sort of classical text on principal agent theory, wrote this, and I'll give you a sort of 10 seconds to read it. You all read quickly, I'm sure. Basically says, if there's stuff you can measure and stuff you can't measure, if you have incentive pay based on the stuff you can measure, but there's important stuff that you can't measure, it's a bad idea and it won't work, because the agent, the employee, is going to focus on the stuff that you're providing incentives for and ignore the other things. So this is a sort of classic teaching to the test problem that we've dealt with or dealing with in education and healthcare and in many areas. This was theory. There's not a lot of evidence here, and it's not completely clear that it is right. And that in medical care, it may be okay to have relatively small incentives for the things that we can measure. Maybe we can get health plans and providers to pay attention to that, and we don't worry too much about everything else. But a question is kind of how much of what is important can we measure? And we heard both from Helen and Sherry about measures that matter. And so I'd ask you to kind of consider this thought experiment. First, think about the highest and lowest performing medical groups in the country. And I would ask, and I don't know the answer, unfortunately, how much difference is there in quality adjusted life years produced by the highest and the lowest performing groups? Now, if we were comparing, say, the highest performing group in the US with the lowest performing group in Bangladesh or Rwanda, we'd probably say it's a pretty big difference in quality. The resources that are available are really different. I'd be pretty sure it's a pretty big difference. In the United States, I don't know the answer. I'm going to posit maybe it's 2 qualities. Maybe it's less than that. I'd be surprised if it's more than that. I don't know if anybody else has any better sense of how many difference in qualities, but unless I hear objection, I'll go with 2. Now imagine we have 2 medical groups, one of which performs well on everything that we are measuring, that CMS and Anthem and other third parties are measuring, and the other performs really poorly, but they're average on everything that isn't measured. How much difference in qualities will there be between those 2 groups? Again, I don't know the answer, but I would posit if it's 2 qualities for the best and worst, it's at most 0.2 qualities for these 2 groups of what we're measuring. Because of course, what we're not measuring is whether the clinicians are using good judgment, whether they are figuring out the right treatment options or the right set of treatment options, presenting them well to patients. We're not measuring, as Helen discussed, we have very poor measures around care coordination. So the sort of point that I'm trying to make here is that what we can measure or what we are measuring is a pretty small part of what we really want clinicians to do. Let me move now to the second point, which is the theory of change. And I think in order to make sense of what should we be doing here, we need some understanding of how and why quality improves in medical care. And this comes mostly from work that Sherry Gleed did in the volume that I mentioned, although it's a bit of an adaptation. I wouldn't completely attribute this to her. But I think it's useful to think about 4 ways in which quality improves. First, by trimming the bottom, the kind of licensure and saying if there are providers who are below some bar, they can't function. And that leads to quality improvement. Second, and I think the major way that quality improves is that new information becomes available, and providers, health systems adopt the new information because that's what folks are trying to do. They're trying to do good. So, we figure out that statins will reduce atherosclerosis. People start prescribing statins, or that stents are useful for people who are having heart attacks. And all of a sudden, people who have heart attacks get stents. New methods of treating cancer. And, those treatments proliferate, excuse me. That's the main way that quality improves. It's clearly not sufficient. We know, all the 17 years from the time that something's figured out to when it's in practice, many things that work. And we've talked today about a lot of delivery system innovations that we have some evidence about working. It's not sufficient, this motivation for improvement, but it is probably the main way it happens. Competitive forces lead to quality improvement to some extent, but there's been much discussed in many environments. Competition in medical care, for a whole lot of reasons, it doesn't exist in many places and doesn't work well at many places, but this is part of quality improvement. And then payment incentives, more in the last 5 or 10 years are increasingly, becoming a way of trying to get quality improvement. And we have certainly seen tremendous improvements in some areas. So I think particularly in the safety area, hospital care is a lot safer today than it was 10 years ago. AHRQ put out reports on this, has been putting out reports every year. Adverse events in hospitals were 17% lower in 2014 than they were in 2010. 75,000 fewer people died. Why did that happen? It was in part because of new information about how to make it happen, the second piece here. But in part, I think, payment incentives and getting the attention of hospital CEOs and CFOs. But it's important, I think, to understand that these mechanisms are very different from how quality improves in most of the rest of the economy. So if you think about selling books, Barnes & Noble sort of figured out a better way of selling books, or a way of providing higher quality, better value. And most of the independent bookstores in the country went out of business. Amazon came along and figured out a better way of selling books, and Barnes & Noble Borders is out of business, and Barnes & Noble is in trouble. And in most of the economy, quality improves by the kind of creative destruction, which is not at all what we want or expect in healthcare, but it is really different. And I think that difference needs to be kept in mind as we're trying to think about how do we actually get folks to improve. And then finally, and I want to get us to the discussion part. As we move towards bundled payments and shared savings payment systems, I think as we're concerned about improving care for high needs patients, that we should be concerned with measuring stinting, because that's kind of one of the concerns about these more high-powered payment systems. And then as Helen mentioned, whether patient preferences are elicited and respected, care coordination, and communication, which is also, part of that is around the patient preferences being elicited and respected. And these are areas in which we don't have good measurements for the most part at this point, and in which we need much more robust investment, I think, if we're going to be developing measures that work. And then finally, one of the papers in the volume that I mentioned, this health services research volume, was from Bob Berenson and Tom Rice. And they provided, I think, a very useful set of recommendations about what to do when relying on using payment, a very flickering set of recommendations, relying on using payment to try to improve quality may not work so well. And they start, and similar to the message that we're flickering around, with the observation that we should be measuring, and having some incentives around those measurements probably makes sense. But we shouldn't have unrealistic expectations that this is what's going to kind of fix the healthcare system or make everything fine, and that we should be focusing on many other policies related to quality improvement, particularly the systematic feedback to clinicians, the provision of technical assistance, and opportunities for collaboration among providers, both within systems, but particularly across systems, as well as making more creative use of CMS conditions of participation. To the extent that we know kind of how things should be, we can put that in COPs, and we don't need to rely on payment incentives to try to get us there. So thank you for your attention, and I look forward to the discussion.